together-facing events really are to support our patients here at Fox Chase. And as part the routine of these types of meetings, we want to have a moment of silence to honor those we have lost to cancer, and also the events that occurred today with another shooting in the United States. And so if we could just have a moment of silence. Thank you. I want to thank our exhibitors. So it's not possible to put on these events, which are so important to, if it's virtual or thankfully in person and seeing everyone, without our exhibitors. So I wanted to thank our gold exhibitors, Bristol Myers Squibb, Caris, Excelixis, Genentech, Natera, and Pfizer. And I also want to thank our silver exhibitors, Castle Bioscience, Iovance, Instill Bio, Novartis, and Sanofi. So we work with all of these partners to be able to move the target forward and find new answers and improve how we take care of patients. So I want to thank everyone. We also want to thank our advocacy organizations, the Melanoma Research Alliance and the Melanoma Research Foundation, which throughout now decades we've partnered with these organizations that provide amazing resources for patients, from education to advocacy, to improve our understanding of melanoma. And so I want to thank them for participating. Everyone can use cards on your table for questions. You can raise their hand later in the program and we'll have opportunities to ask questions. So with that, we're gonna start our discussion. So we have an amazing panel tonight that are all we work as a team here at Fox Chase. I think most everyone in this room recognizes that the care we provide to our patients is not in a silo, and we use what we call multidisciplinary care to talk about patients and come up with the best personalized treatment plan for all of our patients. And so everyone at this table is part of the team. And really, we can't function alone, and that's why we provide such excellent care to our patients. So with that, I'd like to introduce Dr. Saza. He is an assistant professor in the Department of Medicine and one of our amazing dermatologists here at Fox Chase. And he's going to give an overview of how, what patients should be thinking of in terms of identifying a suspicious lesion, surveillance, follow-up, other skin cancers and sun cancers, and sun prophylaxis, so not burning and tanning and using sunscreen. So thank you for being here tonight.
Thank you, Dr. Pharma, and thank you everyone for coming. Let's start by talking about skin cancer. So when we think about skin cancer, there are multiple, but there are three main skin cancers that we need to talk about. So we have basal cell carcinoma, squamous cell carcinoma, and lastly, melanoma. For the basal cell carcinoma, squamous cell carcinoma, we group them together and we refer to as the non-melanoma skin cancer. The reason behind that is because those in particular are less aggressive, have a better prognosis, and are in fact the most common forms of skin cancer. We're going to focus mostly in melanoma. Melanoma is the most serious concerning skin cancer, and that's one of the reasons why we're here today. It happens when some cells on the skin, called melanocytes, transform into abnormal cells and start overgrowing, and this overgrowth has no control and therefore has the potential to spread into internal organs. It's the fifth leading cause of cancer, not only in men, but also in women, so indistinctively of the gender. And also, we have estimated that for this year, approximately 100,000 individuals will be diagnosed with melanoma, and approximately 8,000 will die from this disease, unfortunately. So now that we define what melanoma is, let's discuss who's at risk. So when we think about who's at risk, I like to break it down into three categories. So we need to think of genetic risk factors. There are And a risk is anyone with risk factors. And what are risk factors? Those are factors that we have found that increases your chances of developing this type of skin cancer. So genetic risk factors, unfortunately, are non modifiable. We can't do anything about it. So we come with the genetics. Those are, for example, patients with light skin, fair skin, red hair, also individuals with the familial melanoma. And I always like to explain to my patients that familial melanoma, it's in the very, very few cases of melanoma, less than 20%. Vast majority of melanoma are non-hereditary. But when should we be concerned about familial melanoma? For instance, if I see a patient with a family history of multiple members with melanoma, with history of melanoma, also anyone who develops melanoma at a younger age, less than 40 years of age. And usually when patients have these familial melanomas, those are syndromes that also are associated to other cancers such as brain and pancreatic cancer. So those are questions that I always ask to my patients when we're assessing the possibility of hereditary melanoma. There are multiple genes that have been studied regarding familial melanomas. Of those, unfortunately, approximately 80% are unknown. So the genetic base of familial melanoma are still in a lot of studies. But it is important to know that if you have a lot of family members or multiple family members, I should say, of melanomas, you need to come for a skin screening. So the other risk factors are what we call the environmental factors. We have no control over the genetics, but we do have control of the environmental factors. And the most important one is the exposure to the UV radiation. And the exposure to the UV radiation can be artificial and natural. Artificial would be if you are using tanning beds, which at this point I hope everyone knows is a carcinogen, and we should not use those. But unfortunately, still in 2022, I'm seeing patients who tell me that they are using tanning beds. So we need to avoid that. We already know that that increases your risk of developing cancer. And then we also have the natural sources of UV radiation, which is the sun exposure. One thing that I always like to emphasize is the fact that we need to protect ourselves from the sun regardless of the season, regardless of the weather, throughout the whole year. And the reason why, it's because the UV radiation penetrates the clouds, goes through a window, so we get UV radiation throughout the whole year. So that's very important. Another important thing that we should discuss in terms of environmental factors is the fact that a lot of people don't use sunscreen in the right amounts. And we'll go into detail on how to use sunscreen and so on. Other factors important that we need to consider: if we have a lot of moles, more than 50 to 100 moles increases our chance of developing melanoma. If we have a lot of freckles, we call them solar lentigos, sunspots, as well as ephelides, which are freckles. And that's because that reflects the sun exposure that you have had throughout years. So all those things give us information of how you've been taking care of your skin in the past. And then another important part is to recognize that people with personal history of melanoma have an increased risk of developing a second primary melanoma later on. So those patients also are high risk. Individuals more than 50 years old, white men also are increased risk. But I like to highlight tonight the fact that indistinctively of the skin type, we are all in a risk of developing a skin cancer. Yes, it is a fact that white people have a higher risk in comparison to, for instance, black people, approximately 20 times greater the risk, but we all have to protect ourselves because we all have a risk of developing skin cancer. So then we talk about the risk factors, and then let's talk about how we can prevent or reduce the risk of developing skin cancer. We just discussed the fact that there's things that we don't have any power over, genetics, nothing to do about. So let's talk about the things that we may modify. Let's start with avoiding the artificial source of UV radiation, so don't use tanning beds, sun exposure. So what do we do for that? So seek the shade, it's important. Avoid the sun exposure between 10 a.m. and 2 p.m. So if you want to go for a walk, go for it, but try not to go through that time. Also, use sunscreen throughout the whole year. There are other ways to protect yourself, not only sunscreen. You can use a hat, you can use an umbrella, you can also use protective clothing. There's very cool protective clothing nowadays, swimming suits with SPF or UPF. For fabric is UPF, and I'll explain what it is. So UPF is the factor, the ultraviolet factor protection. It's similar or equivalent to the SPF, which is the sun protector factor that we see in sunscreens, and it tells you the capacity or the ability of the fabric to absorb the UV radiation. What you need to look for is approximately 50. So UPF 50 in clothing is what you need. Same for hats or umbrellas. And then for sunscreen, it's very confusing. We can go into more detail when people start asking questions. But what you're going to be looking for is broad spectrum sunscreen with SPF 30 or higher, water resistant. So SPF only assess the UVA. So we get exposure of UVA and UVB as well as visible light. So the problem is that SPF only assess the UVB. Therefore, the FDA in 2012 decided that there's going to be a new regulation, the guidelines of how to label sunscreens, and now we need to look for broad spectrum, which tells you that in addition to protection to UVA, to UVB, you also get protection to UVA. So if you want to get protection to both, it needs to say broad spectrum. SPF more than 30 protects you approximately 97, 98% of the UV radiation. Then you also have different options. It's confusing for a lot of my patients. There's chemical and minerals. I recommend mineral because they have a very safe profile. They don't give you allergies, flare-ups, and also I know there's a lot of controversies about sunscreens in regarding of carcinogens that have been found, such as benzene. We can debunk all those controversies, but bottom line is use sunscreen all the time, broad spectrum, SPF more than 30. Also, other tools is the self-skin examination. Look for what we call, I like to talk about the ugly duckling sign more than the ABCDE rule. The ABCDE rule for melanoma, which talks about asymmetry, borders, colors, asymmetry, lesions are asymmetric with irregular borders, with different tonalities of browns or colors, diameter more than 6 millimeter, and the E stands for evolution. Anything that changes in size, shape, or color, it's itchy, painful, bleeding. I like the ugly duckling sign better because the study have found that patients tend to forget the whole ABCDE rule. The ugly duckling sign, what I tell my patients, like, look at your skin. Your spots are very similar between each other. They could be like cousins or brothers and sisters. If you ever see something that stands out from the rest, you're like, ooh, it looks ugly. That's what we call the ugly duckling sign. Pay attention to that, bring it up to us, and then that will help us hopefully find this melanoma at an early stage, and it will increase your likelihood of having better outcomes.
Great. Thank you so much. So much. I mean, we could be here for hours because there's so much to talk about. I think the keys are our dermatologists are so important in both the diagnosis of skin cancer and also surveillance. And again, working as a team, making sure that patients are being seen. I'm very passionate about this and vocal, and in terms of tanning salons is $1 billion industry in the United States, and it's no different than smoking as a carcinogen. And there's lobbyists, and we need to change regulations in the country and in the world to help prevent this. We don't want tanning is unfortunately ubiquitous in our society, but we just have to be cautious. We do this job so our patients can go out and enjoy life and go boating and skiing and to the beach and hiking. You just have to be careful. We don't want to tan or burn. So thanks, Dr. Asaza. Next is Dr. Andrea Porpiglia. She is a surgical oncologist like myself, and I'm very, very proud to say she trained as a fellow here at Fox Chase. And she'll talk about some of the changes in the surgical management of melanoma and how we kind of think about melanoma and the options for patients. Thanks, Andrea.
Hi, good evening. So like Dr. Pharma said, I'm going to be talking about surgery and skin cancers. So melanoma is different than squamous cell carcinoma and basal cell carcinoma because melanoma has the potential of spreading versus basal cell and squamous cell. Try again?
Yeah.
So the difference is, all right, is that any better? Any better? Yes? All right, so the difference between basal cell carcinoma, squamous cell carcinoma, and melanoma is that melanoma can spread, and the other two typically don't. Basal cell can be locally aggressive. Squamous cell carcinomas tend to, again, are locally invasive cancers. So when we talk about treatment for these surgically, that's usually the first step for how we treat these cancers. And basal cell and squamous cell, it's typically what we call a wide excision. And melanoma, it's a wide excision, but you also may need to address the lymph nodes and what we do with those. So mostly I'm going to be talking about melanoma tonight. So the way we decide on what surgery to do for melanoma is really looking at the pathology report. So after we get the biopsy, the pathologist looks to see how deep the melanoma goes into the skin, because the deeper it goes, the more likely it is to spread. So the pathologist actually takes a ruler and looks under the microscope and measures that thickness. And that thickness helps us guide how wide of a margin we need and if we need to address the lymph nodes. A thin melanoma is considered to be less than 1 millimeter in thickness, and a thicker melanoma is more than 2 millimeters in thickness. And so for thin melanomas, we may just need a 1 centimeter margin. And for thicker melanomas, we need a 2 centimeter margin. Now, for the patients in between that intermediate thickness, it can be anywhere from 1 to 2 centimeters that we have to take. And actually at Fox Chase, we're participating in a clinical trial that's looking at these patients with stage 2B melanomas. So they're intermediate thickness and thicker melanomas, and we're deciding whether or not we need a 1 centimeter margin or a 2 centimeter margin. And so these patients are grouped into either one. And it's really to look to see, the problem with 2 centimeter margins, it's a wide area and it could be hard to close. And is it really necessary? Is that going to prevent a recurrence? Or is 1 centimeter sufficient? And so we're very excited to be participating in this trial. It's multinational, multi-center, and it really will answer that question of how wide a margin we need for those patients in between. Now, Dr. Patel will talk about a little later, sometimes these lesions are too wide, and so we can't close them primarily, and we need to get plastic surgeon colleagues involved to help with the wound closure. Now, in addition to doing the wide excision, we have to address the lymph nodes. The first step is in the office. So first thing we do is a clinical exam. We see to see if we can feel any of these lymph nodes. If we don't feel a lymph node, that's good, but we still have to figure out if we need to address them. And we look again at the thickness of the melanoma. For melanomas that are starting to get to intermediate and thicker, we have to check the lymph nodes. And there's other features we look for on the pathology report. Something called ulceration, and then there's another thing called mitosis. So how quickly are those cells overturning? And if they have those features, again, they're more likely to have distant spread, and those are the patients that we need to check for the lymph nodes. So the way we do it is called a sentinel lymph node biopsy. So the morning we do the wide excision, the patient goes down to nuclear medicine and they get an injection around the melanoma. And that tracer will travel through the lymphatics to lymph nodes. Now, it doesn't mean that the cancer's gone to those lymph nodes. It's just a map. It tells us where, if the cancer were to go, it's going to go to those lymph nodes, and those are ones we're going to have to check. So the radiologist does the injection, they take an x-ray, and then the patient goes to the operating room. At that point, while the patient's asleep in the operating room, we inject the area with a blue dye. And that blue dye will also go to the lymph nodes. And anything that has the radioactive tracer, the blue dye, we remove. Now, the problem with taking out lymph nodes is the biggest concern is lymphedema or arm swelling. And that can be pretty crippling for some patients. Now, when we do a sentinel node biopsy, the risk is low. It's only about 5%. But when we remove more lymph nodes, that risk goes up. So the problem comes is what happens if one of those patients has a positive lymph node, meaning there's cancer in that lymph node? What do we do at that time? And not too long ago, when we had a positive lymph node, a patient had a lymph node with cancer in it, we'd have to do what's called a completion lymph node dissection, meaning removing all the lymph nodes in that area. So if it was under the arm and the axilla, we'd have to remove all the lymph nodes there, and the groin, all the lymph nodes there. And like I said before, the more lymph nodes you take out, the more chance of lymphedema. And so the question was asked, is it really necessary? Is it going to help these patients if we remove all those lymph nodes? And so there were several clinical trials looking at that. So they took patients in two groups. So one group had that lymph node surgery, removed all those lymph nodes under the arm or the leg, and the other patient were closely observed. And so they would get ultrasounds of that region every 3 months with a clinical exam. And what they found when they compared those two groups is the patients who had the completion lymph node surgery, all those lymph nodes removed, is that yes, it decreased the recurrence there, meaning the cancer didn't come back there as much, but you had the worsening lymphedema of those patients, and the survival between the two groups was no different. So for certain patients with lymph node involvement, with sentinel lymph nodes involved, you may not need that completion lymph node surgery. Now, this does not apply for patients who have palpable lymph nodes. So if you're in our office and we can feel the lymph node and it's biopsy-proven cancer, you do not qualify for the sentinel lymph node biopsy. We have to do that lymph node dissection. Now, again, at Fox Chase, we have some of our surgeons will do minimally invasive lymph node dissections, depending on what region it's in. And the advantage of doing that is that, one, you're less likely to have wound complications, and then two, you have a quicker recovery time. Now, luckily for early stage melanomas, sometimes surgery is all you need, and that's what we hope for. And hopefully, if you follow all the instructions tonight, you'll have early stage melanomas, and hopefully no melanoma at all. And then surgery is all you need. And we just follow you closely afterwards with clinical exam, and as well with the dermatologist. Now, if you have more advanced stage melanoma, then you may require systemic therapy, which Dr. Olzanski will talk about later this evening. But that's all I have tonight. Thank you, and I look forward to your questions.
Great. Thanks, Dr. Porpiglia. How we think of and treat melanoma has changed dramatically from a surgical perspective, and I think that there's a lot of newer options that we have. We're trying to decrease the morbidity or side effects of operations with some of the clinical trials we're doing here. I think in the future, hopefully we won't have to do as extensive operations, and we're already moving forward in that direction. And that's also due to a lot of the new therapies we have, which Dr. Olshansky will talk about, that potentially we won't need to do as extensive operations. However, sometimes we do, and it's always a balance of the complications and risks of surgery, but the chance for cure. And so now we're going to introduce Dr. Samir Patel. He is the Chief of Plastic and Reconstructive Surgery for both Fox Chase and the Temple Health System. I couldn't practice how I practice without a partner like Dr. Patel. He allows us to improve the quality of life of our patients, and it's why working with someone like Dr. Patel is what keeps myself at a place like Fox Chase. So he's going to talk about kind of some of the reconstructions that we have to do for melanoma. And a lot of the melanomas can occur on the scalp or the face or the neck or on the extremities or on the lower legs, where we can't just close the skin up and have to come up with another novel and creative approach to close up areas. So, and then he'll also talk about lymphedema and kind of the amazing things that we have to offer here for patients that sometimes do have lymphedema, and we're changing kind of the paradigm of how we think about that. So thanks, Dr. Patel.
Great, thank you, Dr. Pharma. It's really good to be with everyone today, to see some familiar faces as well, and to see that everybody's doing so well. I want to echo what Dr. Pharma said. Fox Chase is really an amazing institution, and we can only provide the care with this kind of collaborative approach with our physicians, with our therapists, our social workers. It's really a team effort, and I think a lot of the good outcomes that we have are related to this kind of team approach that we take at Fox Chase. And so I'd also like to thank the sponsors as well tonight, the organizers. This is really, I think, a great event for our patients, for our community, and it's good to see such a great turnout. So regarding reconstruction, some of you may be wondering, what does a plastic surgeon have to do in the management of melanoma? And I think that's really kind of a twofold answer. And so, as you've heard from some of our other speakers, melanomas can come in all forms and sizes and shapes and depths, and so, melanomas oftentimes will develop on areas of the body that are aesthetically sensitive or functionally sensitive, and that's, one of the areas that plastic surgeons will get involved. So you can imagine, you heard earlier that sun exposure is a big risk factor. So what are the areas that get the most sun? Well, our face, the scalp, our hands, areas that are really that are not covered throughout the day as we're going about our business. And so one of the things that plastic surgeons will get involved with is in the primary management of melanomas that are in aesthetically or functionally sensitive areas. So what do I mean by that? So things like the eyelids, the lip, the ear, things on the face, melanomas on the face, melanomas on the hand, for instance. Those can all cause aesthetic or functional compromise, and in those settings, plastic surgeons oftentimes will get involved very early to manage the lesion as the primary surgeon. Now, as these lesions get deeper and larger, then we do have to, call in some of our surgical oncology colleagues like Dr. Porpiglia, our dermatologists, to help in the management. But that's one area where the field of plastic surgery overlaps with the management of melanoma. The other area that we really get involved with, and this is much more common, is in the reconstruction after the melanoma has been removed. Now, you heard from Dr. Porpiglia that managing melanomas is a little bit different than managing squamous cell or basal cell carcinomas. Squamous cell, basal cell carcinomas, we don't have to be as aggressive. We don't have to take as much normal tissue. But with melanomas, we do have to take more, and you heard that can be anywhere from about 1 centimeter to 2 centimeters. So that's, anywhere from about half an inch to an inch around the melanoma. So you can imagine that on areas of the body, such as the lower extremity, below the knee, on the hand, even on the face, where the skin doesn't have as much laxity, these larger areas, these what we call defects, can be very challenging to close, right? And so we have to find really kind of innovative or unique ways that we can get some of these defects closed. So what options do we have available to us? Well, obviously, if we can close it what we call in a primary fashion, meaning put a few sutures in, get that defect closed in a straight line, that's ideal, right? We close it, the patient heals as it would any other incision, and they can move on. But in many instances, especially as I mentioned, the lower extremity, on the back, on the face, on the hand, the skin doesn't give us that luxury, and we have to think of some other ways. So some of those things include things like skin grafts. Many of you may be familiar with skin grafts. They're used commonly in other indications like burn care, for instance. In trauma patients, we use skin grafts a lot. The same thing with melanomas. If we have an area that we think can accept a skin graft, we'll use skin grafts to get that healed. So what that means is that we take a very superficial, a very thin shaving of skin from the thigh, we move it to where the melanoma was removed, we put a special dressing on it to hold that skin graft down, and we give that a couple of weeks to heal. So that's one option that we have. If we want to get more intricate or more complex with our reconstructions, we can do something called local flaps. And so what are local flaps? Well, local flaps essentially allows us to move tissue adjacent to the defect or adjacent to where the melanoma was to get that area covered. So we borrow, it's essentially from like borrowing from Peter to pay Paul, right? We're taking tissue from where we have a little extra and moving it to where we need it. And there's a whole different varieties of local flaps. We call them rotation flaps or advancement flaps or transposition flaps. But they all essentially describe this concept of moving tissue from where we don't have it to where we need it. And so again, that's called the local flap. And we can get fancier than that. We can actually take tissue from a distant part of the body. So you can all relate to, or you're all familiar with things like kidney transplants, where we move a kidney from one individual to another. Well, with using techniques of microsurgery, we can actually move parts of the body from one part of the body to another and reestablish the blood supply and have living tissue for us to use to reconstruct. So that's called a free flap. That's essentially where we're taking tissue from a remote part of the body, reestablishing the blood supply by putting blood vessels together, which are very tiny. That's why we call it microsurgery, and using that tissue to reconstruct the area that we need to reconstruct. The goal of the reconstruction is multiple as well, right? We obviously are very concerned about wound healing so that patients can get on to additional treatments that they may need. We're also sensitive to the aesthetics. We want to make sure that that area, especially if it's on the face, looks good, right? So we pay special attention to the aesthetics of it. And lastly, and I would argue most importantly, the function, right? So when we talk about melanomas, for instance, on the hand or other parts of the body that we use every day to perform daily functions, we want to make sure that we don't limit patients' functions, right? And so some of these techniques become very important in trying to optimize the aesthetic, to optimize the functional outcome for our patients. So using, a variety of these approaches, we can really get patients good aesthetic results and good functional results. The last thing that I want to touch upon is something that Dr. Pharma and Dr. Poropilia both brought up, and that's lymphedema. So lymphedema essentially is an abnormal swelling of an extremity. It can actually happen not only in the extremity, but any part of the body. And it results sometimes just sporadically, but oftentimes as a result of cancer treatment, not only for melanomas, but other types of cancers as well. So when we remove lymph nodes, what we find is that patients can get a blockage of that what we call lymph fluid, and it has nowhere to drain. The lymph nodes actually allow that lymphatic fluid to get back to where it needs to get to, which is into the central circulation. And when it can't, the extremity really starts to blow up and to get much larger. And not only is it an aesthetic concern, but these patients have a risk of infection, cellulitis, poor wound healing, obviously discomfort, chronic pain. And so the cornerstone of management for that has largely been conservative therapy, things like compression garments, massage, and you'll hear a little bit of that from Jan in a little bit. And it still remains the cornerstone of treatment. But what we've realized is that there are some surgical adjuncts that we can use to try to control lymphedema. And that includes things like liposuction, direct excision of the tissues, and some newer techniques that are called lymphovenous bypass and vascularized lymph node transfer. And what those two operations allow us to do is, in some cases, redirect that fluid back into the central circulation where it needs to go. Now, I don't want to get in too much detail, but I think the point is that we have made some advances in the management of lymphedema, both from a conservative approach, but also from a surgical standpoint as well. And so, if there's any questions later on in the session, I'm happy to answer them. But that's really all I have. Again, I want to reiterate that, it's really a pleasure to be here at Fox Chase with such great colleagues and to take care of such great patients. And I look forward to the questions and interacting after the session.
Thanks, Amir. Next is Jan Bueller. So she is one of our physical therapists, and she has an expertise in treating patients who do have dysfunction after surgery. It's really important. We've talked about lymphedema, and we're very cognizant of that. And we really try, if there's patients that we think who are higher risk of lymphedema, to have Jan and her staff and colleagues see patients even preemptively before surgery, so we can have a strategy in place with either compression garments or stockings to help prevent that. So Jan will talk about our physical therapists here and our lymphedema program. Thanks, Jan.
Okay, so you've heard a lot. I'm from physical therapy. Rehab, I'll deal with occupational therapy, physical therapy, and speech, all of which could be impacted by surgeries, by radiation treatments. Okay, so the guys, the research has made these surgeries less toxic than they used to be. Radiation treatments are less toxic than they used to be, but there's stuff still out there. The rehab team, we work on restoring function. So whether that's because tissues are too tight afterwards, or there's muscles had to be removed because of the tumors, whatever. Okay, so we deal with functional mobility, getting you out of bed. We're right on the whole continuum. As was mentioned, we can be done pre-op, and we give them training. We teach them about possibilities that can happen afterwards, such as lymphedema. Not everyone gets lymphedema. They take all the lymph nodes and they still don't get lymphedema. But a lot of people, it's a risk factor, and it's a risk factor for the rest of your life. You add that to radiation, that's a bigger risk factor for the rest of your life. So we like to let people know this up front, as opposed to like, well, I never heard that. So we fill in the blanks that sometimes they're, it's very hard to listen through some of these multiple conversations through multiple providers. So we'll potentially see them pre-op. We might, if we think it's going to be a risk, we might have them measured and or sent to get a compression garment that they may wear preventively afterwards to try and minimize the risk. The earlier we catch lymphedema, the better we usually have the opportunity to control it lifelong. Okay, in the hospital, once these surgeries are done, they've got to start getting out of bed, they've got to start moving, they've got to be able to get back up their stairs. Sometimes people get too weak from the procedures, and we may make a recommendation that instead of going home, maybe you need to go to an inpatient rehab, that once the medical side is done, you still have functional strengthening to do. So we make those recommendations. Sometimes, well, you can go home, but you still need some work, and we can make recommendations for a home PT to come out to the home, again, to help out. All right, later on, even still, like you're potentially, we work along the entire continuum and anywhere down the line. So as healing further happens from the acute treatments, then stuff might show up, such as, well, more weakness, or if they're on the chemotherapy, there might be peripheral neuropathy. Well, now that's interfering with gait. Or we might need to make recommendations for how to use an assistive device. All right, if radiation's there, radiation, the gift that keeps on giving, so forever there's potential for more tightness, more weakness that didn't show up 2 months afterwards, didn't show up 2 years afterwards. 10 years down the line, it can show up as more problems. Or, you now have a 10-year-old system, so the lymphatics that were working or be able to still compensate when you were 45, maybe when you're 60, it's a little harder, okay? So we can see you anywhere and intervene. We like to keep an eye on lymphedema. We sometimes will follow people for inguinal node, which is the groin, or in the armpit if those surgeries are removed, if those nodes are removed. Sometimes we'll follow you for a couple of years even, and we just try and be very preemptive about trying to identify a problem before maybe you recognize it, or maybe you're saying, well, it just feels off, and you know what, you're right, why don't we do something about it? So this can be recommending garments, or the actual treatment itself, in case it shows up, is a manual treatment, which most people don't complain about. All right, so we use our hands. We try and teach you a self version of that. Compression, if we have to be more aggressive, we get dynamic with bandaging. If it's not so bad, we can make recommendations for garments. And we do our best to help you recognize and to self-treat where possible. Okay, fluid is heavy, so trying to lift a leg that's really, like got 8 pounds of fluid in it because it's swollen makes it very difficult. Okay, so anyway, so that's where rehab fits in.
Thank you so much, Jan. Next is Angeli Albanese, and I think it is so, as the theme of the night, I think, again, working as a team and having all these resources here at Fox Chase is so important to all of for personally and to the patients. I work